Hey everybody, welcome back to Stand By for Tones podcast. With you today, you got Isaac and Sam, and a special guest today, we have Brian
Hetrick.
Hello, everybody.
We've got Brian Hetrick today, and hello.
Dude, I am so excited for this right now.
Yeah.
I have been waiting for our first podcast guest forever because I've wanted it to be Brian forever, and it's finally happening. He came all the way from Florida to teach a class and happened to be in town. And, dude, welcome.
Thanks, buddy.
We're so excited to have you here. And I guess the big thing is Brian, tell us who you are a little bit.
Yeah.
I'm B. Hetrick RN, man. That's who I am.
B. Hetrick RN. The man, the myth, the legend.
Yeah. What can I say, man? I've been around doing some of this medical stuff since like 03.
Nice.
Yeah, man. I got my EMT basic in 03, and that was the first step after I figured out that I was probably not going to medical school. So
Fair enough.
it's like
You're honest.
Yeah. You know, I always thought I was going to be a doc, and got to college, and it wasn't the academics. The academics were fine, but I became more learned and realized, nope.
Yep.
That is not the way.
This is the way.
This
This is the way.
right. This is the way. That was
Yep.
not the way. Yeah, man. But so I had to figure out what I was gonna do because that was the only goal I actually had in life, and then it went away. And so so I ended up getting my basic in 03, and that just snowballed after that. So went from basic, and then obviously I went to medic school. I was a medic for about 4 years, 5 years, something like that. And in that time, worked EMS, worked in the trauma center, in the ER too. And then after I swore up and down that I was never going to nursing school, because why do medics want to go to nursing school?
Right.
Scratch, man.
Yeah, it happened. My wallet started screaming at me. So I ended up doing the transition thing, man. I went to nursing school, and I've been a nurse since 10. Yeah.
Sweet, man. You became a nurse and accomplished all that in the year that I got my EMT license. So,
Well,
not to date you at all. You're old.
it's true. Yeah. I wish I could deny that, but I just can't. Yeah.
Oh, that's funny. How's the family? How the kids? Everybody's good?
Yeah, man, everything's good. Let's see. Kids just came back from summer camp, so
Nice.
they love that. It's always great when they leave.
When they leave, exactly.
Get to hang out at home for a little while without the kid mess.
It's
But
like sending them back to school.
but yeah, wife just opened up her practice mid-May.
Oh, yeah. How's it going?
It's going. It's just like any other business, though,
It's
right?
just like us. It's got growing pains.
It's got growing pains.
Yep.
Yeah, it takes time to build clientele and get your name out there and do all of that. But slowly but surely, man, we're getting somewhere.
I love that.
Yep, it's cool.
Yeah.
Well-
That could be huge. And
I'm hoping that it is going to be. I believe it's going to be. It's just
Yeah.
going to take some time to get there.
Yeah.
Yeah.
she's going to be your sugar mama.
I sure hope so.
Erica, if you're watching this,
Good job.
good job. But yeah, man, no, that's awesome. I'm just so excited to have you here more than anything. And, we're really lucky to have you come by, and, it's just going to be super fun. And I just appreciate you coming all the way from teaching a class, coming here. I mean, you went straight from teaching a high level ventilator course to having dinner, 2 hours away,
Yeah.
and then into a podcast studio.
Yeah.
I mean, like, it's been a whirlwind of a day. So why don't we get
Anything
down?
for you, man.
You're so good to me.
Yeah.
For the background here, Brian and I were flight nurse and paramedic partners for a couple years at our old agency that we worked for together. Had a lot of fun, did a lot of learning, a lot of growing, and just a lot of really kind of neat things together. It was just a friendship made a work friendship that turned into a lifelong friendship.
There you go.
Yeah.
It's been great. And we got some cool things planned for today. We're going to talk a little bit about ultrasound. We're going to talk a little bit about some sudden causes of death. We're going to go over maybe some ventilator stuff. We kind of hit that quite a bit. And then we're going to let Brian give us a little talk on some of the things that he's passionate about. So
sounds good to me, dude.
it's going to be
Yeah,
good.
we'll see. We've got a kind of a list, but we'll see where it takes us.
Yeah.
So
Yeah.
I'm
Who
not,
knows where it's going to go?
Not worried. We're gonna have fun. So.
Yep. I got a Boba Fett cup full of drink, and life is good. All right.
Awesome.
Where do you guys want to start off?
How about ultrasound? Let's start off with the ultrasound.
Yeah.
Yeah.
We can definitely get into ultrasound. We had some really good conversation about this earlier, and I think we just continue that talk. I love where it went.
Yeah.
And there's people that are going to love it. People are going to hate it. And I like all of it. So
Yeah, that's true.
I think we'll get right into that.
Yeah.
So ultrasound it's one of those new things for EMS. So something that not everyone has yet. Not everyone wants it. Some people think it's great. There's, I don't know.
Some people have it and hate it.
Some people have it and hate it. Some people just, that's all they want is ultrasound. So we get a couple really cool perspectives here. So for me, I don't have ultrasound. I've never gotten to use it. I would love to use it. I think there's great potential for it. We have Sam, who has been on both sides. He's been able to use it before, doesn't have it now.
Mm-hmm.
And then we've got Brian, who
Has it
actively
now.
uses it. So
Yeah.
3, I think, good perspectives. So we're going to, jump into it. Sam?
Yeah. So that's almost like queso for me. Yeah. So queso.
Queso.
But ultrasound, man, like you and I went through ultrasound training around the same time. We did high-level ultrasound training. We learned to love it, but trying to fit it into practice has been hard to me. It's been hard for me in ways just for the fact that I don't know if I'm proficient enough in it per se to be confident in my assessment and how it's going to guide it, because really what it was broken down to is that this is confirming a suspicion that you already have. And I don't know if that's the real right way to look at it. I don't know if you have a different perspective on it. I don't know if you have different thoughts on it. But really, ultrasound was great when we were first playing with it. It was the new, cool, big, bad toy. And like we said, this is going to be controversial for a lot of people. But I don't know if I'm 100% sold on it yet.
So I'm kind of on boat with you, I think, in the sense that, it is the new big thing, right? And so many people are jumping on the train. And yes, I accept that there's evidence out there for what ultrasound can show you. But I kind of tend to agree with you in the sense that if you've got decent assessment skills and you've got some experience and you've been around for a little while, a lot of what the ultrasound is going to show you is stuff you could probably have figured out or can figure out based on good assessment.
Yeah.
And so my question that I ask with relation to that is, how much is the ultrasound really affecting course of treatment for patients?
That's the day. That's the
Yeah.
the question of the day. I mean, does ultrasound affect our treatment care path? And from what I used of it, is the last time I had a chance to use it was on a trauma arrest. Guy yard sailed his car, going at a high rate of speed. Get to him, he's peri-arrest. Get him in the back of the helicopter, and he arrests almost immediately after movement. And it's just like, okay, we're in a very limited, confined space. So that was kind of my only assessment tool, is I could plug it in really quick and stab it on his chest and be like, okay, the beady things that's supposed to be beating isn't beating. But I also knew that because my end tidal CO2 was shit. I was in, not a wide complex, but a Brady arrhythmia that was, coming down from some form of PEA, if it was PEA. And then he was in respiratory arrest, and the ventilator's just cooking away. But I mean, all it did was confirmed what I already in the back of my mind knew.
Yeah.
And did I need to do it? Did I need to take that time out of my care process to, plug the ultrasound in, put jelly on his chest, and get a good, 4-chamber view of the heart?
Right. Yeah, no, and it's, you can make the the argument will get made, the case will get made about pulses, for an example, right?
Yeah.
There's material out there that says that even seasoned EMS people are terrible at actually checking pulses.
Oh yeah,
I 100% agree because I'm terrible at it.
Yeah, right. And
I am terrible at it.
And it's not just like, and I don't mean that in the sense of like they don't even check, even though there's probably the case for some as well, as sad as it is to say, but will feel and say, oh yeah, there's no pulse, but there is. Okay.
Yeah.
So
or the opposite. Yeah, I feel a pulse and there isn't.
Exactly.
Yeah.
Yeah.
Totally.
Well, I mean,
sure.
I was just doing a case review on a chart that there was a blood pressure of 143 systolic, and they were doing CPR on him. There's a lot to this whole topic, right?
Yes.
It's very complex, and this ultrasound thing. I mean, like, I get it. POCUS is the focus of the nation. Like, that was a good rhyme, and I didn't even try.
That was good.
POCUS is the focus of the nation right now for EMS professionals. And the hardest thing to wrap my head around is just, I mean, like, I understand the why. I really, really understand the why. It is a great secondary assessment tool, and it was never meant to be a primary assessment tool. And how do we get that paradigm to shift?
Yeah.
If that makes sense.
No, it does. It does. And I think that's probably one of the big obstacles to using the ultrasound in the first place is it's not in people's habit to use. And that sounds like an excuse, right? And it's like, well, I don't use bougies because I've never really used one before, so therefore I'm just not going to do that.
Yeah.
Right?
Yeah.
Okay.
No, it makes perfect sense though.
Not really acceptable, but I understand where you're coming from, kind of situation. And somebody might say that, about the ultrasound situation where you say, well, I really don't use it because it's not really been a part of my practice, and trying to find a way to squeeze it in is hard and whatever. And you could say, well, we just need to work, we need to work with crews. We need to work with timing of your calls, right? About finding a way to get this in there. You've got to figure out where you're going to put it in, make it a habit, do it at the same time all the time, that kind of a thing. I think a lot of that has been done, and I don't think it's working very well. Just going to be honest, right? People, they want to see, medical directors and whatnot, want to see more ultrasound being used, but they're struggling to get people on board. Part of that, I think, like I said, is it's about habit. It's about how you've already crafted your assessment skills.
Yeah.
Right. And the other is this question that we're bringing up is really, what's the point? Because why am I going to add time on scene? Why am I going to delay transfer? Why am I going to do any of that? When the decisions that I'm going to make with regard to patient treatment probably aren't going to change very much, regardless of what I see on that ultrasound,
Correct. And then not only that, but it's another assessment skill, right? It's not, besides a tool, it's also a skill. It's something that you have to know how to do correctly.
Yeah.
And know what you're looking at.
Yes.
So if you haven't used it in 6 months, it's like, oh, great, here's a perfect time to use it.
Mm-hmm.
Right.
I mean, the skill of it, I don't think is the hardest thing. It comes down. It's just like,
that's
but
part
finding
of the skill too.
but finding the landmarks isn't the hardest thing and to do. I mean, body habitus changes and things like that. It's just like airway. Like, it's, once you kind of figure out your landmarks and things like that, you can find a way to it. But how long does that take you? What are you even doing this for? And we talked about this a lot at dinner. It's just like, I had a couple cases, like my last major trauma, like put in a chest tube without needing to verify with ultrasound on lung sliding. Like, that didn't change anything.
No.
And then I had the complete opposite, where I had a kid where ultrasound doesn't even really, it's not even, how am I trying to say this? It's not reliable in kids as much as it is adults, just for the fact of volume spaces. And, there's a whole myriad of things that change that. And I delayed bedside time because I had a multi-system trauma that I wanted to do an ultrasound on. That I already knew was going to have a hot belly.
Yeah. Well, and also, like, talking about reliability in pediatrics, right? It's also the fact that depending on who you work for or what populations you work with, you may not be getting a lot of practice time even on doing PD ultrasound assessments.
Correct.
Right? So even if I'm doing one, how reliable, how much can I trust what I'm looking at?
Yeah.
And is it fair for me to make a decision based on images I'm not necessarily used to looking at in this population?
Yeah. No, it makes perfect sense. It's hard to wrap my little paramedic brain around because I want to love it so much. I want to love it. And I even asked for it at, the new agency after I changed agencies. Like, I asked why we can and cannot have it. And they gave me very good reasons and some blurry reasons on why it's good and why it's not. And, I've kind of fallen in line with that and, haven't found that I've missed it is the biggest thing. It's like, I loved it when I had it, but now that I don't have it again, I don't miss it. And I don't know which way to sway myself in it.
I don't know. Like I said, I'm on the outside, right, looking in, basically one of those guys that, I think it'd be great, right? As we're talking through this, I'm going through multiple scenarios in my mind, especially when it comes to flight, like, especially when we're flying. Now, I think that could be super helpful for me with assessment skills. Like, things are changing, and I can't listen to lung sounds.
And that's what it was intended for, right? It's not intended to be doing it on the side of the road. It was intended to be used in flight, like after initial stabilization to, as your secondary assessment tool to be able to pick up and find these things that are going wrong. Because, I 100% agree with you. I can't listen to lung sounds in the back of a helicopter. Yeah. Like, if I can put a probe on their chest and see pleural lung sliding, that's great. But the other side to the things like ultrasound reads a lot. Intraocular pressures and, ET tube placement. So there's ways to, gauge intracranial pressures. There's airway conformation and everything from your FAST, your EFAST, and, just being able to go through all these things. But it wasn't ever and this was my fault mostly, was I didn't use it in the right time in the right place. And that was all on me. So I don't know how to make that more apparent to people that are using it and how it needs to be used in the correct time, because we can't delay our initial treatments. We shouldn't be delaying our initial treatments, loading the patient, ruining our golden hour in a trauma patient to do an ultrasound on the side of the road when we can do it when we're, 15 minutes into flight.
Yeah. No, I agree. And I think it shouldn't be utilized for the stuff that we can figure out without it.
Yeah.
To be honest, I don't need ultrasound to tell me that this person needs blood every time.
Yeah.
Right.
IVCs are great, but hypotensive, tachycardic, trauma patient, either the blood's inside them or outside of them.
Yeah.
Like, you've got two options.
Yeah. No, it's true. It's true. But IVC assessments might be useful, in some cases when you're like, well, am I going to do fluid? Am I not going to do fluid? But here's the question again, right? If I think the patient needs fluid and they're not obviously overloaded,
they probably need fluid.
I'm probably going to give them some fluid anyway.
Yeah.
Now, I might give them a little less than I might give somebody else because I'm not sure how far down that line I am.
I agree with that.
But
potentially.
I'm probably going to do it anyway.
Which I'm going to move just away from that just a little bit and go to a good question here.
Yeah.
How do you know when enough fluid's enough? When do you stop giving fluid?
That really comes down to fluid responsiveness more than anything.
Good answers.
And
that's what I was hoping to hear.
I
heard it.
Fluid responsiveness is huge. That's one of the things that we're trying to pound into, younger generation paramedics is like, don't be afraid of your vasopressors, because if you give that first liter, maybe that first liter and a half, and you don't start seeing subtle changes in your vital signs, i.e. either heart rate or a slight increase in your blood pressure, they're probably not going to be fluid responsive, and you can start using your vasopressor therapy as you're continuing to fluid resuscitate them.
Correct.
Yeah. Because, those things are supposed to be done in conjunction, not one after the other. And, that was a huge misconception for such a long time.
Yeah. So that was perfect answer. And so exactly what I wanted to hear is where I was going to get to. If you didn't answer it, but you did, and so I'm very happy you did.
Sam,
But
you're
yeah,
so smart,
it's-
Sam.
It's because I worked with you for so long. Come on now.
It's exactly that, right? Are they responding to your fluids that you're giving them? So you're going to see that. And again, fluids is not, I give them 100 ml
Yeah,
bolus.
don't tickle their
Right.
feet.
No, yes, of course. Of course.
I gave them a liter.
Yeah.
And
Pressure bag it in.
I pressure bagged a liter in, and did the heart rate get better? Did blood pressure get better? Did anything change? Yes or no? You know, that's the kind of
It's
stuff.
algorithmic
Again,
thinking.
I don't need an ultrasound. I'll bring it back to ultrasound to
Yep.
tell me yes or no whether that fluid's working. But there are times when I had a really complex patient where I don't know why he had a heart rate of 50 and a blood pressure of 50 as well. Like, why isn't he responding? Is this a beta blocker thing? Is this a neurogenic shock thing? I don't know. He was found unresponsive. Nobody knows. So
Yeah, I mean, it could be a
being able to
cardiogenic
check
shock.
IVC while I'm doing a bolus, while I'm getting pressures going, and I'm literally waiting there like for the next blood pressure, that'd be a perfect time to use it to say, damn, he's low on fluid. Let's keep it going.
Or like, oh shit, his ejection fraction is terrible. Because
Yeah.
some of these new ultrasound probes will give you an ejection fraction without
That's
even
cool.
asking it, which is pretty nice. Like, I know the
Ejection
new
fraction, please.
Yeah,
Like
yeah.
Siri.
yeah, you push the little magic button on the side and it just does it. I mean, like, there are some cool things. Like, ultrasounds IVs were fun to learn. I never had a chance to use it, but
I
you
just
know,
get an IV.
there's an IV or an IO. Like, that hasn't changed, right?
Yeah.
And like, the success rate of an ultrasound IV for somebody who's not skilled in it is about the same as somebody that's just going in for a blind stick.
Yeah.
The one thing that I did love about the ultrasound, and this will kind of come into our 5 major causes of sudden death, was an aortic assessment.
Yeah.
Because you have that unspecified chest pain radiating into the back, whether they say it's tearing or not. Maybe it would prompt me to go and say, maybe I should ultrasound your aorta, but I don't know if it would. Like, at that point, I would chest pain it.
Yeah.
Like if you just had a standard person come up to you, they're skinny and frail, and says, I have chest pain and it's radiating to my back. Like, would you scan their aorta to see if they had a DeBakey 1 through 3B? Like,
Right?
Probably not.
probably not.
Yeah.
I mean, it's an assessment tool that we could add to it, but I really don't know if there's, I hate to say, I don't know if there's a place for it yet. I think there is,
Well,
but I don't know.
I think they've been able to show you or show us as providers that there's some usefulness
Yes.
to it. I don't think you could argue that, you know, putting an ultrasound on somebody and taking some, even if you're getting amazing pictures, right? Like, even with taking amazing pictures, yes, I can confirm, yes, I can confirm, and yes, I can confirm.
Yes.
But if I suspect, then I'm going to address, and it doesn't really make that big of a difference. So I think, personally, it's overrated
I like it.
at this point.
It's great.
And you know, like you said, like, you also have to, you know, as a company using ultrasound, everybody's got to be in it to win it.
For
You
sure.
know what I mean?
Yep.
Because of the proficiency.
Yeah.
Right? So everybody's got to want to be in the game. They've got to want to practice. They've got to want to learn how to do this.
Got to get naked with your coworkers.
Promote shirtlessness.
Yep. That was one of my email titles at one point, was promoting shirtlessness at the workplace. But the other part of that too, Brian, is like the quality assurance after that. Like, you have to have somebody that is dedicated to go in as well and just be like, hey, like, this was what you said you saw, but this was their guts. Like, this was their butt or something like that. Like, that was
Right.
completely wrong.
And you made a decision
based off
based
of
on
looking at their
something you
butt.
thought you saw,
Yeah.
and it wasn't right. What you saw was not what you thought.
And
you
so
saw.
how do you do quality assurance and quality improvement after that is another huge thing, because EMS in general is already strapped for money. Like, how are they going to justify paying someone just to go through ultrasound? And,
Mhm.
you know, there's so many parts to this puzzle.
Yes
that
and
are
no. 'Cause
not
how are you making that decision anyway? Why did you decide to do this based on whatever you've already documented and what their vital signs are to begin with? So,
Yeah.
It's
I like this side of the table, your side of the table, which is a little more skeptical of it because you've used it and right versus me.
Mhm.
So I'll play this side where like I want it.
yeah.
You know?
Don't get me. I would love to
So-
see it come back, but with a better understanding of its purpose.
Yeah.
Like I would love to see it come back. I would love to be able to be like, oh, tube confirmation done. Pleural lung sliding, great. I got ants marching. I got Sandy Beach, or I got barcode. Whatever it may be, don't give a shit.
Gotcha.
Like it's great to be able to do that in a noisy helicopter.
Yeah.
But we're seeing that it emerge its head in the pre-hospital EMS environment, and I don't know. Are we ready for that? Are ambulance
question.
clinicians ready to do ultrasound? We're not ultrasound sonographers. I don't even know if that's the right term for it. But like, we didn't go to sonography school. We went to paramedic school.
Right.
Is this the time and place when we're having such a hard time? I read a post earlier today from another co-educator that I've worked with before that made a whole lot of sense, that they're having hard times with paramedic students in paramedic school because of the COVID days, because they can't pass basic math and reading comprehension. So is this the time to be putting in, ultrasound and broadening something like this, because we can't even get providers to pass math?
First of all, you need math.
Yes.
Stay in school, kids.
Do drugs, stay in school.
I tell you what, my daughter gives me that question all the time about why do I need this math? And I love math.
You are a nerd.
I love math because in our hospital world of everything's gray, there is no black and white. Math's black and white.
Yep.
And that is my absolute favorite thing about math is there's an answer. So do math.
Math
Yes.
is good.
Do math. And I have to
Not math.
Not math.
Meth and math don't go together. No, and interesting that you say that because, and talking about like paramedics having trouble passing math, right, to get through their programs. I think I'm also beginning to find, unfortunately, that old school med math and like drip calculations is becoming a lost skill.
Oh, it is.
100%
with
dude.
people.
I love my partner currently because she's an
Oh.
old school nurse,
Yep.
right? And she makes me do old school math.
Yep.
There was one
And
day we
I
were
love
sitting
it.
in the back of the helicopter and she was like, all right, calculate your drips for me in 3 steps. And I was just like, Mama Cheryl, you're going to have to teach me your ways.
Yeah.
Like,
Yeah.
like teach me the way to do this quickly. And she rattled off this quick formula and it was like that. It was done.
Yeah. We've gotten it down where, I mean, she's doing a drip. I'll do, again, old math. I'll find the constant and I will figure out what the rate should be. She'll program it in. She said, what should my rate be? I tell her what it is off my constant and off my math. And it's, matches her pump. She's like, cool, we're good. Like, perfect. Love math.
And that's how it should go.
Really? It is. And that's how I used to teach at the college too, was I made everyone do long formula math to begin with. You do long formula math until you get that down, and then I'll show you the shortcuts after. But
which it's just, it's hard because we put so much time into, these little math equations to make them so much easier.
Yeah.
And, then you go in and do, reaffirmation or something like that.
That's right.
And it's just gone. And it's like, are we just giving dosages off of a whim? Or like, are we just picking a number out of the sky to, give this patient like just because you want to give this amount of medication doesn't always mean that's the same amount of mLs, because not everything comes in a 1-to-1 concentration.
Right?
correct.
And
Yeah. I mean, I don't know how many times I go in and to an inter-facility or whatever it is, and they're running some med, but it's completely different
concentration than what you would mix.
Yeah. So you have to figure that stuff out.
Yep.
So do
Or,
math.
God forbid, we could all get on mics per kilo per minute and stop using mics a minute for some of our medications and having to convert it from mics a minute to mics per kilo per minute, which is the bane of my existence. It's super easy, but it's just like,
I don't want to do this.
I don't want to do this right now. I can't take you in mics a minute. I have to convert you to mics per kilo per minute. And that's just one of the parts that I see with math. I don't even know how we even got on math.
Just divide by their kilos. There you go.
Yeah. Yes, I understand.
Divide everything by 2.2. That's it.
Yeah,
You're done.
I understand. I understand this. I don't know how we got on math, though.
I don't know
Let's tailor back to and finish up ultrasound really quick. Math was fun. Don't get me wrong. It made me sweat a little bit because I do love math, but it really gets frustrating when, we put so much time and effort into understanding the math and it's just gone. But anyways, here nor there. Back on ultrasound. Am I a fan favorite? I think in the moment where all of my management was in the classroom, not wearing any shirts, hanging out like we were all bros again, enjoying the time, learning hands-on, one-on-one with our physician was one of the most fun trainings I have ever done in my entire life.
It was fun.
It was fun.
Yeah.
Like, we had a blast. There was nothing could go wrong that day. It was absolutely one of the best training days I've ever had. Does it fit my current, and this is my current, side of where I'm at right now? No, because A, we don't have it, and B, because I have began to rely on my assessment skills that have been, factually and clinically proven to work time and time again over the years, whether that's Beck's triad, tension physiology, Cushing's triad, and just, the trauma triangle or diamond of death, whatever you want to call it. Like, we have these assessment techniques that work so well. I don't know if right now is the time for it. Maybe as the patient population changes and our education changes a little bit more in pre-hospital, then it might fit a little bit better in the times. That's my stance on it. Whether you agree with that or not, that's my opinion.
That's my opinion. It's mine.
So.
Everybody is entitled to their own opinion.
That's
yes,
right.
They are. Just remember, surely not everybody was kung fu fighting. Okay. Any last thoughts on ultrasound? I know I would love to see it come back. I really
I
would
so
love to see
again,
us
it hasn't
get
gone away for everybody.
It's,
It's for, I guess, us. It hasn't really even gone away. We just haven't had it for our specific department. So,
And they've given you
man.
reasons why.
Correct.
Yeah.
But
And do you see, I don't know what they've told you, but
it comes
do
down
you
to
see those
assessment.
reasons changing?
That's a hard question.
good question.
Not
Not
one
right
of
now.
our medical directors is he's not against it, but has his reasonings why he doesn't think it fits the agenda. And that is usually based off of it's not great in pediatrics. You have to have so many mLs of blood in the abdomen at time of assessment for it to be a positive FAST exam, which is 100% true. So that means you have to do it at least twice during transport, at the beginning and at the end, if you don't have a positive initial. And that, it confirms our already pretty darn good suspicion. If you have an open book pelvic fracture and they're, hypotensive and tachycardic, what are you going to do? You're going to put a pelvic binder on them, and you're going to go ahead and give them your fluid resuscitation and your blood. What ultrasound is not going to change, it's going to tell you that, oh, sure, like there's blood in the pelvis, but we already addressed it.
Exactly.
And so that's how they have laid it out to us, which I can't argue against. And every time I try to argue against it, I find more and more reasons, especially after my first chest tube and being able to, trust my assessment skills, knowing that what I'm doing is the right thing to do and not having to rely on it.
Yeah.
And that's what it has come down to every time since I've talked about this subject.
I got you. One of the sorry, a good thing that we talked about at dinner too was you do that fast exam and you don't find any blood. But so now are you less keen to do the interventions you would have done if you didn't do that fast?
Yeah. Right? And maybe the reason your fast exam was negative, possibly, is either because you caught it too early and there's not enough volume present where you're looking to find anything.
Yeah.
Doesn't mean it's not there.
Correct.
Just means you haven't gotten to the point yet where they're from a sonographic. Is that the right word? I think it's the right word. Right? Positive. You know what I mean?
Gotcha.
So yeah, so if there's bleeding happening, but I don't see it, does it change what I'm going to do? Should I think, should that knock me off? Should I then be off guard and be like, oh no, everything's fine, right? When in reality, right, I have to understand I got to understand the bigger picture of what happened here, right? What happened to this person? Mechanism of injury, all the other things, right? Like how fast, how far they fall, I don't know, whatever, right? But you've got to have the bigger picture of what happened and know that you should be expecting these things and be surprised if they're not there, not if they are there. Does that make sense?
Yeah. You reverse psychology did almost.
So
almost. So again, I think it's not so much, it's not your primary assessment. It's, you can use it for, again, confirming suspicions.
Yeah.
Or I think for me, the best way I see it is like, I'm lost here, so I'm going to the ultrasound.
Can I find something?
Can I find something to sway my treatment, to change my differentials?
Yeah. Sure.
And
I think that's valid.
I think that's a great way to look at it. And the biggest thing that I tried to instill when we went and started training other people on it was that it's a tool. Yeah. Just like everything else that we use in the aircraft, the helicopter, whatever it may be, it's another tool to help in aiding your already good physical assessment.
But we don't use all the tools all the time.
Yes, it's true.
Correct.
You're not wrong. But I didn't use ultrasound all the time when I should have too. This is a tough subject. This is good. This is going to get people riled up, man. This is going to be, because I just saw a video the other day of a paramedic standing in the back of an ambulance that says, if you're not ultrasounding with your agency, then you're behind the times and not doing it right. It's just like, well, let's take a step back here. Yeah. Like we've done EMS really well for a long time. Just because we got ultrasound doesn't mean that, we're doing it better now. Because like we talked about, it could be a detriment.
Absolutely.
So, ultrasound, man, that was brutal. That was like 30 minutes of brutal. My armpits are moist.
Moist.
They are moist. Like
best word in EMS.
Yes, is moist by far.
Moist or creamy. Which I think we've said this before. So,
Brian, what is your? I'm going to put you on the spot here. What is your EMS golden rule today?
Oh.
My golden rule is don't panic until I panic.
Which I love. Explain more. Elaborate.
So that's what I tell patients, right? And a lot of that is usually geared towards people who are high anxiety, or the ones that you walk in and they start asking you 1,000 questions right off the bat.
Yes.
Gotcha.
A lot of times because whoever and wherever they have been cared for has not bothered to really talk to them, explain anything to them.
What?
I know.
That's going to get me
not talking to their patients?
Crazy, right?
Crazy.
That's a good one.
But yeah, so a lot of times, we fly a lot of people who are really sick and really injured and are in their critical phase, right? But we also fly people who are sick but not that sick.
Yeah. We're taking the hot appy from one little hospital to another little hospital.
Right. But in any of those cases, whether it's to the patient directly or it's to the family, usually when we walk in, right, like people always assume that if the flight crew is here, something is really bad.
Yeah.
Right. It's got to be really bad.
With especially as rural as where you and I used to work, or I used to work and you still work, but like it was either completely benign or it was real bad.
Right. Yeah. And it's true. But what I like to tell the patients and like to tell the families, who are obviously anxious and obviously concerned and sometimes even over concerned, is
What?
is
People concerned from their families, how dare they?
right. Is I always like to tell people, listen, you don't have anything to worry about. You don't need to panic until I panic. And until I look like I'm scared and until I look like I'm not sure what to do, everything's fine.
I love that.
I like it.
That is great. Isaac, what's yours today?
I don't have one today.
You're a liar. You always got something. I guess I'll do mine. My golden rule for today is don't be afraid of professional controversy, because really it's okay to professionally question somebody. If somebody comes into you and you're taking care of a patient and they say, yes, their blood pressure is 40 over nothing and all of these things are going wrong.
There's nothing wrong.
We're going to give them some push dose epi, but we don't need to start a norepi infusion. To be able to confidently ask them why you don't want that to be done and provide that little bit of confrontation, because maybe there's something that they're seeing and haven't elaborated to you yet, or maybe it's something that they're feeling uncomfortable with even in the right scenario. So professional controversy is an okay thing, one done tactfully and appropriately.
Therein lies the key. Tactfully and professionally.
Yes.
Right?
Yes. You don't have to come unglued, anything like that. It's just a simple, why do you not want to do this treatment? And it can just be as simple as that. And whether that's good enough answer for you, great. If not, professional conversation and continue with your treatment path.
Nope.
Gotcha.
I like that. I think that's really good.
No, it's good. Controversy is okay.
Yep.
Yeah, it's good to have the conversation. So,
because I've also asked a doctor,
man,
what do you think about, and got the hand that said, I don't care, do what you want.
Yeah.
Or
there's also that.
Yes.
Or the ones where you come in and the first thing that they tell you is, this is what you will not do.
I love that.
And you're like,
But now
so
I
you don't want me to put
right?
Jet A in the aircraft. Okay.
okay.
You shouldn't say that because then that's all I'm going to think about. Right?
Mm-hmm.
It's like you can't tell somebody not to do something.
See, I just had that situation the other day, kind of tailoring off. I guess it wasn't the other day. It's been quite a few months, but we had a kid with pretty severe DKA, and one of our protocols is to call the receiving PICU facility, which is fine. Like, I've gotten over it. It used to bother me, but it doesn't anymore. And the receiving said that they didn't care how fast the blood sugar dropped, and if it dropped more than 100 milligrams a deciliter, they didn't care. I was just like, carry on, Wayne, or party on, Wayne. Right? Like, if that's what you like, document.
Yeah.
Like, that was documented. Like,
yeah.
We only dropped the blood sugar 100 milligrams over the course of an hour, which was
strong
fine.
work.
But
Strong work, Sam.
Yeah,
That's
thank
good.
you.
You're welcome.
But at the same time, it's just like, those are hard statements to swallow sometimes. So,
yes and no.
Yeah.
Only because I have the diabetes and I drop my sugar all the time.
and
but I'm not in DKA when I do it. So,
Yeah. Exactly. There's that market difference there.
Market difference. Yes, I get that.
Okay. Did you come up with your golden rule yet?
No, we're going to move on.
Okay, moving on. So one of the big things that I found while searching the interwebs for our little podcasty poo today that I found that was kind of fun was a GEMS article that I'll cite it correctly since I'm in the middle of college. It is from gems.com by Corey M. Slovis on 01/20 of 2015.
Slovis with how many?
MD, FACP, FACEP, FAAEM.
I don't even know what those mean.
I don't either. But so this
I know
is
what two of them mean. Does that make me special?
I know what MD means.
I didn't know Slovis was
FACEP is the Fellow of the American College of Emergency Physicians. I know that one.
Oh, man, you're smart. This is why we asked you to be here. Make us look good, please. But anyway, so this study is about 9 years old because I can do math. And this is all about the 5 common causes of sudden unexpected death every EMS provider should know.
Cool.
I thought this was really interesting, not only on the fact that it's all things that were taught in school, but things that could always be brushed up on. So starting off with number 1, I know somebody's got a story of lethal arrhythmia.
All arrhythmias are lethal if you die.
So yeah, it's so true. All arrhythmias are lethal until they die. But some of the big things that we forget to look at, especially when we're taking like a 12-lead EKG on somebody with palpitations, is long QT syndrome, delta wave, short PR, anything that could be pointing you to a WPW. And like I said, that long QT syndrome, we got to be watching out for a lot of these medications that, our mental health population is on, can promote these long QTs. And then we have medications that we give to treat lethal arrhythmias that will promote a long QT as well, like amiodarone. Like if you give amiodarone to somebody with a long prolonged QT syndrome, kind of in a crapshoot on whether it's going to convert it or not, or they could just, spontaneously go back into it. There's a lot of these things like VTAC and VFib and torsades that we need to kind of remind ourselves on how to treat. And really it comes down to are they stable or unstable? Do they have a history of prolonged QT, which is a question that many people don't really ask. I don't ask it all the time.
Never ask that question.
Or a history of WPW. Like those are some just quick and easy questions to ask for the tachyarrhythmias. Just because WPW can rear its ugly face in the worst time that you would ever want it to and not really know about it. And then you give something like Cardizem, and then they go into an uncontrolled atrial fibrillation at 300 beats a minute. Then you're cardioverting them and just making the whole situation worse. So there's a whole lot of things that go behind it. But
just shock it till you recognize it.
Shock it till you recognize it is what it was going to come down to. But
Hallelujah.
At the same time, we need to make sure that we're really good at, reading the squigglegrams.
That's where I was going to go with that is just like some med math seems to have kind of fallen off the track.
Yeah.
I feel like some of the subtlety and nuance of EKG interpretation as well is falling off the track as well. And I think it's something that there needs to be a kind of reawakening of if you're going, especially in our arena, I think if you're going to fly in our circles, pun intended,
That was good.
Thanks, buddy. You've got to be up to par on this stuff.
Yeah, you have to be confident reading EKGs.
Well, and even for things like like we may even get to that, I don't know, but things like Scarbosas and Brugada syndromes, being able to recognize
STEMI mimics.
Scarbosa criteria.
The STEMI
my
mimics.
gosh. Yep.
Being able to recognize that stuff. Now, hopefully when you get there, they're not flatlined. Because that's an easy one.
Right.
Yep.
Flat is bad.
Push, blow, blow. Make the liquid go round and round.
But yeah, these like you said, like WPW.
Yeah.
For a lot of people now, that's hard.
Yeah.
Oh, it's been a minute for me.
Yeah. I mean,
I'll be honest.
There's a lot of these little, just kind of random arrhythmias that then they're not little, they're life-threatening arrhythmias that we don't typically cover anymore. And a lot of people don't really understand is how electrolyte imbalances play into this as well. I mean, you've got anything from, hyper K-induced tachy and bradyarrhythmias, because you got to remember, as they progressively get higher, they're going to go tachycardic before they get to their peak point, and then that's when they lose their P wave and their QRS starts dropping off. Then they get extremely wide and bradycardic, and then they slowly go into a sinusoidal rhythm of death. And by that point, you're already way behind the ball game. And if you can't look at an EKG and be like, "Oh, that's a rolling M waveform that I was taught in 2010 in paramedic school," and know that that's a hyper K sinusoidal rhythm, then we're going to be behind the ball game in these situations. But the big thing to remember is be confident in your ACLS skills, be confident in your medical math and your knowledge, and your ability to read these EKGs is going to be your top priority. Thoughts, questions, concerns?
Don't be afraid to say you don't know,
Yeah.
and take the time and effort to either ask
Yes.
or just go home and study, man.
Yeah.
Get some books and go home and just practice. The number of resources now in books. See, I said books. That makes me sound old because you used to have to just
books.
you used to have to just get books for stuff. Now there's so many online resources.
Yeah, like
that-
Life in the Fast Lane is a great one.
Yeah.
I'm not afraid to point out other resources on our own
Nope,
podcast, but
Not
like
at all.
The
You know,
EKG
life-
guy.
yeah, the EKG guy, Life in the Fast Lane, YouTube. I mean, like the Googles, as my uncle Scott would say. Have you checked the Googles? But I mean, like you just Google and like you get a pretty good explanation, and then you can even throw in their freaking AI if you wanted to, and just like have it do whatever you want it to
I was
do.
gonna say, make the AI test you.
Yeah.
I bet.
Look at 5.
Thanks, buddy.
That's good.
That's like
That's going to be a new project for us.
that's like 2 good thoughts I've had in less than an hour. I'm
Yeah.
impressed.
No, I completely agree with that. If you don't know, figure it out.
Yep.
And remember, there's a lot that you don't know. So
Indeed.
that's for all of us. I mean, again, if I don't understand something, whether it's for this or doing rope rescue stuff that we do, like if I don't know, I'm gonna go make myself an expert on it and teach somebody else. Because then when they ask you questions, I mean, you have to know those answers. So
Yeah, and we can take it even one step further before we move on to number 2 is getting a basic foundation of axis deviation, because that right there alone will help you determine an SVT with an aberrancy, so something that looks like VTAC versus true ventricular tachycardia in itself. And having that basic understanding of just axis deviation and how electrical flow works through the body is that next step process. Not only can you identify them, but then you can be able to discern different rhythms from other ones because of the different flows of electrical waveform.
guess I know which class you're teaching next.
Oh, are we teaching axis deviation next? Okay. So number 2, acute myocardial infarction, commonly known as AMI, and with the rise of the OMI manifesto is starting to come out. I don't know enough about OMI to do a podcast on that bad boy yet, but I'm sure we will get there. OMI stands for the people that don't understand it, occlusion myocardial infarction.
Oh, cool.
And that is the new kind of STEMI criteria, because the STEMI criteria has been garbage. From what they say, I thought it's always worked fine because we progressed from Q-wave infarct to just being able to do STEMI, ST elevation myocardial infarction. Now we're going to occlusion myocardial infarction. So we'll see how that comes out over the test of times. But the OMI Manifesto is a really good resource if you guys ever want to read it. I actually was kind of reading it earlier today because I am a nerd. But acute myocardial infarction, basically when you get some big form of plaque development within a coronary artery and you start getting myocardial tissue oxygen demand issues and your heart stops effectively pumping. And that's probably the easiest way that I can, explain it, but it can lead to ventricular tachycardia, it can lead to pulseless electrical activity, and just asystole based off of whatever is going on. And this is another one that I feel like has gone kind of downtrended in their education is 12-lead reading in just today's national standards.
Yeah, I think you're right. Again, with relation to arrhythmias too, though, I think they got these go hand in hand, right? As far as being able to get a tracing, look at a tracing, and be able to make some definitive decisions, confidently, based on what you see. But yeah, like I know some nurses that work in some high places, and if you gave them a 12-lead,
look at them squigglegrams.
They wouldn't, unless it was, unless we're talking about like screaming
a janitor,
tombstone.
STEMI,
Like the picture right here.
Yeah, where
Yeah, kind of like that one.
the janitor can go, ooh, that's bad.
Yep.
But if it's not like blatantly obvious, there could be some challenges there.
No, I get that. And
this is where I'm glad I went to medic school first.
oh, dude, I am so blessed and happy that I became a paramedic when I did, especially from the college that I went to. just for the fact of our in-depth of cardiac knowledge that they gave us, and feel really, really good about that. Isaac, what are your thoughts? What do you think about ST myocardial infarctions?
Yeah, they're bad.
The true medic himself.
No, it's a obvious something that you should be looking for. Do your 12 leads.
Yep.
Read your 12 leads.
When do we need to be doing more 12 leads or less 12 leads, do you think?
I think 12 leads are great.
More 12
Probably,
leads.
definitely more 12 leads.
They're applicable in overdoses, hypoxic injuries, shortness of breath, chest pain, unspecified back pain,
Generalized weakness.
Unspecified abdominal pain. And then the big one we'll talk about, I don't know if it was in this segment or...
I think even just AMS, like altered, right?
Altered mental status. There is a section that we'll talk about S1Q3T3 for right ventricular,
Strain
enlargement,
patterns.
strain patterns that can, be indicative of some things like pulmonary embolism. It's number 4 for us, so it'll come up next. But some of the things that we really need to kind of look at when it comes down to, it won't come up next, we're on number 2, is the common clinical signs associated with acute myocardial infarction. You're not always going to see all of these things, right? So we're going to have dyspnea, diaphoresis, CNS symptoms like syncope, dizziness, stroke-like symptoms, GI upset and weakness. I mean, like, I haven't had a patient that says, I'm going to, shit myself and then has a big MI, but I mean, like, they can get an upset belly and, just that nausea, vomiting more than anything.
Yep.
So the classic presentation doesn't always fit the clinical picture, is I think what we're trying to get at with this, is because the atypical chest pain patient is so rampant these days. And I mean, I had a guy walk into one of our local ER facilities and was just up a shit creek. Ended up on an Impella. We were, giving him vasopressors and doing all these things. And he walked in with chest pain at 45 years old, and that's where he lie.
That's a challenge for sure.
Yeah.
Well, and in like this case too, remembering like the differences in genders, you gotta, statistically, females don't present in a typical fashion at all. It can just be
that's MIs and everything else. I
right.
agree.
Yeah, I'm just saying, like, sometimes for them it's nothing more than some nausea or abdominal pain.
Yep. Yeah.
And you throw a 12.
It's either pregnancy or heart attack.
And if it's not a heart attack, pregnancy is going to give you one. So,
right? They take all your money. But no, I mean, like, there's some really good information that we can provide on this. Maybe we should start looking at a 12-lead mastery class. I've been seeing people looking at, we have so many classes that are going that, this will be one that's down the line, but it's
just add it to my list.
Add it to the list. Thanks. Right? Okay, let's move on to number 3. We got intracranial emergencies. This is one of my favorites, and I love this picture. Maybe we'll pull it up on the camera there. Intracranial emergencies are bonkers. They can be some of the hardest patients, to control blood pressures on, to continually do neuroassessments on, to, discern, why is this altered mental status happening? Why is this seizure happening? And there's so many things that could be going on.
Yeah.
The nervous system, like, it's just crazy. So this head CT scan was a 77-year-old woman who collapsed early in the morning, was found down by EMS and noted to be hypertensive.
I think that's a lot of it too, is that hypertension.
Yeah. And
most ones I've had that are just sudden like that, it's they have that big history of uncontrolled hypertension.
Yep.
Yeah.
And
they finally blow the cork.
And then it's just, and it is exactly that. It's they're fine and then they're not fine.
Yep. And, I find it hard to control blood pressures in some of these patients. Dugan and I just had a pretty substantial intracranial process patient a couple months ago where we had to titrate our nicardipine like 15 times because like we'd go up by like a 0.5 milligram and it would just tank the blood pressure. And then we'd take that half away and the blood pressure would go up by like 100 millimeters of mercury. And it's just like, this is frustrating.
Oh, yeah.
This is frustrating. So, Brian, do you have any tips and tricks on blood pressure control?
Well,
not to put you on the spot.
no. What I was going to say is sometimes those patients that, you're trying to use one modality
Yes.
to get the blood pressures down, and you're finding that that's what's happening when you titrate. You go up by a sliver and the blood pressure tanks, and you come down by a sliver and you're right back where you started, and you're like, what in the world do I do? Of course, you should follow all of your local protocols.
Thank you.
But it's when you need to consider, it's when you need to start thinking about what other modalities can I do in addition to this, and see if you can I create like some symbiosis here, and
that's a big word.
Use more than just one modality in an effort to try to complete your goals. Like if you're just using nicardipine and you can't seem to, that this is the trouble that we're running into.
Yep.
Okay, what other options do I have?
Are there options labetalol?
Okay.
Don't forget about fentanyl.
Oh yeah. Pain control. Pain control's huge.
Benzos.
Benzos.
I mean,
yeah.
your neuro exam on most of these patients is probably out the door anyway.
Yep.
You know what I'm saying? Like as far as getting good neuro exams. Well, because
Neuro
like
status
we
unchanged.
We have to document neuro exams every 15 minutes.
every 15 minutes.
Every 15 minutes on any intracranial process, we have to document a neuro
Cool.
exam every 15 minutes.
Like what neuro exam are
An
you trying?
action EMS charts neuro exam of slurred speech, facial droop, arm drift, change in mental status, and things like that. Are they better or worse?
It's just
Every
But
15
you're not
it's just
having
like
to
an
do-
ICU neuro
But you don't
assessment.
have to chart on a full like NIH.
You don't have
No.
to do a full NIH, but you should be doing a full like ICU
Sure.
neuro status, just like a stroke patient for the
Yep.
first.
What you're supposed to do. Well, never mind.
What
That's
is
a
it?
conversation
Is
for
it-
a whole nother
yeah,
topic.
it
But
is, but yeah.
but yeah, no. So no, I could see where that gets frustrating, right? But how many times have you had an issue, where it's like, well, when I get where I'm going, they're probably going to want some sort of a neuro exam. They want some sort of physical exam.
Yeah.
And if I snow them,
Yep.
then they're going to get mad at me because now I can't get my exam done.
Yep.
But I think, valid point, if you're in true hypertensive crisis, as it were.
Yep.
You've got to make a choice here.
Yep.
Right? Do I let this persist and make whatever problem is going on worse? Or do I make a doctor happy so they can get a exam when they show up?
Yeah.
Yeah.
You know what I mean?
We're fairly lucky
When they're going to
in-
throw them in a CT anyway.
Yeah. Yeah. Or the teleneurodoc's going to come on and
Yeah.
watch us do our assessment.
Exactly.
And we're pretty lucky with how our docs respond to that for the most part. They're actually really, really good about 90% of the time about how we treat our patient assessments and our blood pressure management and pain control management, which is really nice. Some of the big things that we kind of commonly forget to think about is in, head bleed situations, head of bed elevated is always good. About 30 degrees is usually about where we want to land at.
BLS before ALS?
Yep, BLS before ALS. Yes, reduce that intracranial pressure, promote venous drainage. And then with our embolic strokes, head of bed flap is kind of
What if
our
they're in a
protocol.
C-collar and they didn't clear C-spine yet?
Yep. Or what if they're in a C-collar and they didn't clear C-spine yet? I'll put a horse collar on them. I'll put a towel roll on them.
Are you still going 30?
Yeah, because per Nexus protocol, you can sit up at a 30% or 30-degree angle.
Perfect.
Yep. So, not to quote the Nexus protocol, but if you guys follow Nexus, don't forget that you can sit your C-collared patients up a certain amount of degrees before it becomes invalid. So, yeah, do you guys, how do you feel about head of bed flat for embolic strokes? Do you guys follow that?
Yes.
Yeah, especially for our large vessel occlusions, we do head of bed flat. We do a lot of large vessel occlusion transport. A lot.
Why? Why flat? What are we accomplishing?
The reason that we do flat is because the neurosurgeon called and said, keep them flat. And I said, yes, sir. Anything else I can do for you?
Well, in that case, I think you've made the wisest decision that you can make.
Yeah.
I'm not sure exactly why. I do know.
Yeah, I'm not. That's what I was trying to like ponder there for a second. I was like, okay, if we're gonna do that,
I think it.
what are we accomplishing?
I really think it promotes our cerebral perfusion pressures because just by laying them flat, you get a 7 millimeter mercury increase of cerebral perfusion pressure.
Look at you pulling numbers, man.
And
Tell you what.
I don't think the venous drainage outweighs that in an embolic stroke. And so I think that with the head bleed situation where we're trying to promote the blood being out of their brain versus in their brain, that it plays as big of a factor is kind of the way I think about it.
Gotcha.
And the only reason I pulled that number out of my ass like that is because I just heard it the other day.
Nice.
So, but
another thing I like on, I know we're kind of all over on topics, but something I always ask for, or if I didn't get a chance to talk to the neurosurgeon and the ER doc doesn't know, is liter of fluid with those embolic strokes.
Oh, yeah.
A liter.
Now we're talking about your cerebral perfusion pressures, right? So
yeah.
In that case, on that point, what are your MAP goals?
Ooh.
We didn't do anything off of MAP goals. We did everything off of systolic blood pressure goals. So our intracranial hemorrhage is below 160 systolic, and then I can't think of it off the top of my head. I have to look it up almost every time for our embolic stroke goals, but
so I find that interesting, only because I'm trying to think about my stuff too. I think it's pretty much everything is
140 to 160-ish.
well, everything is systolic,
Yeah.
guided.
Yep.
Or MAP greater than or less than, and then a number, right? Depending on what you're dealing with. But it's the ischemic. It's the ischemic embolic ones, right? Strokes that we're allowing for permissive hypertension on.
Yep.
Right.
Yep.
So if I
our
walk,
systolic max is 220, so we want to keep them below 220.
That's
I had to think about that for a second.
That's where I'm at too. But I'm with you. If you walk in and you have a known ischemic stroke, and you've got a MAP of 70, am I perfusing enough around that? I'd say no.
No.
Yeah.
I would say.
But I'm not only giving fluid just for their maps.
Yeah.
But again, just making sure those vessels are full, making sure they're tanked up as well, because it's just like when you get a kidney stone, whatever it is, you're going to get fluid. Try to open up those vessels. It's going to make passing that stone a little easier. Same thing when they're going to go pick out an embolic stroke.
Yep.
They're going to go in their brain and pick out a clot, making sure that they can do that.
That's nice, dude. Yep. That's a good one.
Yeah, our neurosurgeon sends us our
I've got
retrieval after every patient.
Yeah,
so
that's awesome.
Cool clot picks.
Yeah.
Yeah.
Which is pretty dope.
But yeah, it's interesting that, to just that perspective, like I look at it as MAP goals.
Yeah.
When I look at those.
Yeah. I love a MAP goal.
So I look at, what's a normal MAP? What's my normal range for ICP?
Correct.
And if I add those two things together,
Get your CPP.
Right? Yep. I get my CPP from this.
Which is, if you don't know, cerebral
perfusion pressures, right? And I know that I need a minimum CPP of at least those two numbers added together.
Yeah.
So for me, usually when I look at it, it's around 90.
Yeah.
So if I don't have a MAP right around 90,
not feeling gravy.
I'm not feeling too good about it. Yep. And so
I get that.
Their blood pressures might be fine on a monitor, But yeah, in that case, I'm gonna want to do the same thing. I'm probably gonna want to throw a liter of fluid on and see, can I just bump them over that edge, to try and make sure that you're getting those adequate perfusion pressures to perfuse around.
Yep. And I've actually seen multiple times given that liter and watching that neuro exam get better.
Yeah. Don't know
It's
why.
weird. Just again,
I guess perfusion
perfusion.
pressures. That's
perfusion
that's what
pressure
we're
and just
talking about.
dilating
Yeah.
those vessels, right?
So.
Yep.
But often neuro, we talk quite extensively about neuro. If you are not familiar with, the difference between an epidural versus subdural versus intraparenchymal, subarachnoid, any of those, make sure you go ahead and research those because those are good. They have different onsets. They have different, vague symptoms that are present beforehand. So those are good things to go ahead and review on.
Yeah, you can buy our book too.
Yeah, or you can buy our book. I do like our book. We're getting great reviews on Amazon. So to whoever who's reviewing those on Amazon, thank you so much. Pulmonary embolism. The second to last one before we wrap up with Brian's little talk tonight. We're just going to go through this really quick because we've been talking for about an hour and a half already, and pulmonary embolism is a great thing to talk about. So I had a pulmonary embolism after a motorcycle accident, ended up on a ventilator for 14 days in the ICU. It sucked. I didn't know if I was going to live, but I didn't know if I was going to live or not because that's the weird thing about medicine is once you're on a ventilator, you don't remember much. Some of the
If they're doing it right.
Yeah, no shit, right? Some of the common causes of pulmonary embolism, stasis of blood flow. So that is what hypoxia, everybody?
Yeah,
What hypoxia would that be?
Well, you got to put me on the spot like that.
Yeah, it's one of the four.
Stagnant.
Stagnant hypoxia. Very good.
Just
So
needed a second.
Yep.
Right.
So stagnant hypoxia where we can't move the blood adequately through the vessels. So this can be anything from cardiogenic failure to, sedentary lifestyle. We can have hypercoagulable states, and this comes down to the woman triad. So they're female, they're on birth control, and they are a smoker. Those are putting people into a hypercoagulable state. And then you also have to think of the cancer patients as well. They get frequent pulmonary embolisms, DVTs, all of the clotting issues in general. And then we have vascular injuries, which was trauma, even kind of the relatively minor stuff can lead to these things.
And obviously, I think the most common PEBC is the post-surgical patient, right? So,
Yeah.
Yeah. They're post-surgery, so they have a form of trauma and they're, a sedentary lifestyle. Like, that's a big thing. And because, that raises a whole nother question of what kind of surgery did they have? Or did they get, platelets? Did they have to get blood products? Did they have to get all these other things that are going to change your coagulation factors in general? So,
there's a lot of them. Pregnancy, so many things.
yeah. So let's talk.
Then you had COVID. Oh,
COVID.
man.
Yeah, those are no words.
I don't even want to get into that, but
Stop, don't touch me there. That is my no square.
Tried to block that out.
right.
So what comes with acute pulmonary embolism is you have to remember the flow of blood, right? That goes from the right atrium to the right ventricle to the pulmonary artery, through the lungs to the pulmonary, through. Why can't I talk
through the
tonight?
pulmonary system?
Yeah, through the pulmonary system. I can't talk for the rest of the night. And then it goes into the left atrium and left ventricle. If we get a blockage in that pulmonary system, so the pulmonary artery, the only artery that carries deoxygenated blood, we are going to start seeing increasing of right ventricular and right atrial pressures,
Correct.
which is where S1Q3T3 comes in. We have to remember that it is not just an indicator of pulmonary embolism, but it's also an indicator of pulmonary edema, something like, I can't remember the name of that, right ventricular hypertrophy secondary to pulmonary hypertension. I don't remember what that's called, but there's a lot of things that can cause that right ventricle to stretch out, and that really comes down to being able to remember how we read our pressure monitoring waveform our pressure monitoring waveform numbers and how we map them out, because you're going to get the higher pressure on the dammed side of the blockage. So anything from the blockage upstream is going to be a higher pressure, causing injury and insult. And that's where these electrical abnormalities come through. So S1Q3T3, if you guys aren't familiar with it, you're going to get a slightly pronounced S wave in lead one. So remember, the S wave is always going to be your last downsloping part of your QRS before it gets into your T wave section. So you see that that S segment there. And then we're going to go to lead 3. Your Q wave is always going to be your first negative deflection. So you're going to Q wave in lead 3. And then you're going to get a flipped T wave in lead 3 as well. This one's kind of hard to see. I'll see if we can get a better picture. But those are the good clinical indications of S1Q3 T3 and that right ventricular hypertrophy secondary to right ventricular overload from a pulmonary embolism or something that is blocking that pulmonary system. Patients drop dead fast from pulmonary embolisms, and one of the biggest clinical indicators is anxiousness without cause, is the way I like to think about it. Is if you go on that patient that's pale, diaphoretic, can't breathe, they're anxious, they don't have anything to be anxious about, pulmonary embolism should be high on that suspicion list, because that's the one that's going to get you. That's the one that you're going to move out of the car that they've been traveling in for 4 days, and they're going to code on you right there and then and there. That's what I got for that section.
I like it.
Yeah?
I think you did great, Sam.
Oh, thanks,
That
buddy.
was really good, buddy.
Yeah, thanks. I'm going to let somebody else talk for a minute. So aortic catastrophe.
I'll jump in on PE real quick. So
Yeah.
just to remind you, if you haven't seen pictures of PEs and these giant clots, remember they're big clots. They're not like just this tiny little thing. I mean, they're big. So yeah, big clots.
Yep.
That's all I have. Big clots.
Saddlebags.
That's
Ooh,
right.
I like that. We'll see if we can
Saddles.
find YouTube might take it down if we have a
Might
picture of
block
clot
me,
on there.
right?
So
Oh, there's a great video. You might not be able to post it, but there's a great video of which you may have seen, where their chest is open and they've opened the vessel and they're removing the PE.
Wow.
Pull the clot out, and this thing was huge.
Let me see if I can pull up the video while we talk about aortic
Just
catastrophes.
Massive.
Aortic catastrophes.
Talk to me, Goose.
Is that bad? No, yeah, aortic catastrophes for sure. Again, anytime I go on any patient with abdominal pain, it's one of the things that pops in my brain is, hey, AAA.
Yeah, it's a differential diagnosis.
All right, I'm gonna make sure I rule that out. And I think we talked about this recently, maybe not. I think
we did because I had a really bad aortic patient a couple months ago.
Yeah, just again asking those questions of that abdominal pain. Does it radiate to your back? Does it radiate down towards your legs? Right. If they answer yes to those, then I'm like, woo, freaking out a little
Right.
bit. So
Doing bilateral pressures,
yes,
right?
Yep. That's a very missed step. And then the other thing too is like skin temperature. Something so basic like what is my skin temperature from this side versus this side? Like
it's a good one.
So simple. Like
It
my
is.
last big aortic patient, his left leg was freezing cold and his right leg was perfectly fine. Like it's crazy.
Yeah.
And these little assessment tips that just completely go unnoticed, and like paresthesias, like what goes with blood loss, paresthesias. So like if you're not perfusing that extremity or that side of your body, you're going to start getting numbness and tingling and pain and pallor and all of these other things. The 7 P's of of artery occlusion kind of play into this as well, because they're not getting that arterial flow that they want.
Gotcha.
So poikilothermia, another great word.
Look at you.
Man.
Remember what poikilothermia is?
No.
Poikilothermia is when the body assumes a room temperature. So it's basically like how lizards live. So
You become a cold-blooded, well, never mind, you already are. That's okay.
so yeah, the devastating side of things is aortic catastrophes are extremely hard to repair.
Yeah, they are.
Depending on what it is. Remember, DeBakey 1 is extremely serious to DeBakey 3B, and then you can have combinations of all of them intertwined. Like my last one was an A through a 3B that extended from his iliac bifurcation all the way to his aortic knob. And they got in to do his surgery, and they went good thing we called the family.
Yeah.
Because it was
That bad.
that bad.
Yep.
I still think it's about 50%. Flip of the coin whether they live or die.
Yeah, it was a very humble conversation because we had a chance to let our patient call his wife before he went into surgery, and knowing what was going to happen, and the provider that was there was even like, there is a high likelihood that he will not come out of this. Yeah. Like there is, I think the number was a 10% chance of surviving this from the time we enter those doors. Damn. And it was like, it gives me goosebumps to think about because I got to witness somebody's last phone conversation with their loved one. And it's kind of a weird thing to think about on how just kind of humbling that is.
A little bit.
Yeah, very humbling. So one of the big things that come up in critical care examinations is widened mediastinum.
Yep.
So remember to be able to look at your chest x-rays, go through your ABCDE of chest x-ray interpretation, one of those being the C being cardiac, and not only measuring your cardiac silhouette, but looking at your mediastinum to see if it's widened or not, indicating some form of aortic injury. And that's going to pertain, a lot more to our interfacility transport side of things where you're going to have that, because I don't have an x-ray machine in a helicopter.
No.
If I had an ultrasound machine,
should we get X-ray too?
It'd be fun.
No,
mobile CT,
Like
helicopter
that.
CT.
Hey man, we're putting CT scans in neuro trucks now.
Yeah, I think
CT in
neuro
an
ambulances.
ambulance.
I think neuro ambulances are sweet. I think that'd be kind of a sweet gig to do. You know, stroke care in an ambulance right in the back, like just like they do in all those weird fire shows where they're slamming TNK through an IV on the stairwell, hoping that it's not a head bleed after somebody fell down. like it's just wild what some of these guys come up with. But
That show is terrible.
I hate medical shows.
Was it Station 51 or?
I hate them so much.
No, it's one of those like Chicago Fire,
gosh.
Chicago something.
Yeah.
It's-
Yeah, it was wild. But I take it you've seen that episode.
I have seen that.
Yeah.
Yes.
So, just kind of the roundup of this little section here is we just want you to be really familiar of like the sudden causes of death. I mean, there's so many sudden causes of death, and we can add a sixth one of trauma, but I mean, like these are medical causes of death. Yeah. So, just remember to do your assessment. I mean, like this whole episode is kind of wrapped around assessment is what it's really kind of ended up being, which I love because we don't talk about assessment enough. But on that note, Brian, I'm going to put you on the spot, and I want you to talk to me about something that you're passionate about. And we're getting to almost an hour and a half of this conversation.
So keep it short.
And no. You're fine. I'm just extremely grateful to have you here. And I want you to blow some mind holes of your favorite things.
Blowing some mind holes. Okay. Well, so the thing that it's really been on my mind for several months now, actually, and we talked about this a little bit while we were eating. This industry is full of type A, right? Type personalities, people with trust issues, control issues.
I do have control
issues. You have control issues? Never.
Yeah.
Right?
Just a lot of it.
Perfectionists, right? You got a lot of people who walk down that road as well.
Yep.
And because of that, a lot of times when we find ourselves fresh in this career path, we put a lot of hours in, and we put lots of money in, and to try and get the experience and get the certs and pass the tests, and we spend all of this time trying to prove ourselves up to a certain point where we can become a part of this new community, right?
Yeah.
Where we get involved in this transport community, this critical care community, right? We want to up the game. We want to do something bigger. We want to do something better. And it's real easy, and I can speak for myself, that when I first applied for a flight job and got hired in a flight job, I thought, I deserve this.
Yeah.
Like I've earned this.
Have you seen your brains?
But it didn't take me long to figure out that as much as I thought of myself, I was not nearly as smart or educated or equipped as I should have been, or as I was going to need to be.
Gotcha.
Right. And so, one of my big things related to that is imposter syndrome. Right. So, what happens is we hire new individuals into this flight community, into this transport community, and these are all people who have these personality traits. They're all smart people. They're all educated people. And everybody thinks that because they are now in this environment, they're here because they figured it all out.
Yeah.
And it doesn't take long. A week in academy is probably enough to figure out, okay, so I thought I knew some stuff, and now I realize I don't know anything.
Yeah.
Right? Everything I've done up to this point was elementary, my dear Watson.
Yeah.
Right?
100%. I mean, like, speaking from experience, that was me in my first ventilator class with Randall.
Yeah.
Like, 100%.
Oh my gosh, yeah.
I thought I came in being the shit at being able to do this, and then I sat down with a true ventilator expert, and my mind melted, and my tail was between my legs.
Oh, yeah. Yeah. And, like, I came on a little a ways before you did.
Yeah. And
Randall beat us up hard. Because, and in retrospect, it was 100% warranted.
Oh, yeah.
It had to be done. It
Yeah.
absolutely had to be done. But it was, it's, you get into like I was saying, you get hired, you get into academy, you get into the beginning of this, and suddenly you have all of this work on you. You get all of these assignments, all these books to read, all of these other things to practice and modules and everything, and you just get swamped, right?
Yep.
And a lot of it's new stuff. A lot of it is stuff that you were like, these are the things where you're like, oh, yeah, I am retarded. I didn't know I was, but I am.
Yep.
Yeah.
Can I say retarded? I don't know.
We'll buzzer it.
But it's that like drinking from the fire hose metaphor.
Yeah.
Right. And it's real easy to suddenly find yourself in this place, in this situation where you were super confident and now you're super not confident.
Yeah.
But you don't want anyone to know that you are where you are.
Yeah.
And you keep that, you try to keep that to yourself as best as you can. Right?
Yeah. So
we start actually seeing these patients. We start riding third, and we're working our way through the process, and we're seeing all of these things where suddenly it's like, I've never had to make this decision before. I've never had to make this decision before. I've never really had to perform this skill before.
Yeah.
I don't have a lot of proficiency in it. I thought I was good, but now I realize, like, there's way more stakes in this game than maybe I kind of really realized in the beginning.
Absolutely.
And you're afraid to say, I don't know what to do, or I'm confused, or I just need help.
Yeah. Or I'm over my head for a minute.
Yeah.
Yep.
Yeah. I'm over my head right now. And so what happens is that people find themselves they might find themselves feeling kind of depressed. They find themselves losing confidence in themselves. And they find themselves trying to hide their lack of confidence from other people.
Yeah.
So then they start trying to put on a show for the people around them. They start trying to, they want to play the part. They want to sound the part. They want to feel like they belong in this group of people around them. And for some folks, it becomes a struggle. It becomes a real internal struggle to try to keep up with all of the work that's being assigned, to try to grasp all of these new concepts, to try to understand all of this new information and make good decisions. And that over time, if we're not open with each other as partners and as coworkers, in order to try and address these situations with people, because what a lot of these new hires who do experience this, what they don't understand is that all of the people who came before them probably went through some phase of this as well.
Oh, 100%.
You know, and we need to be able to create an environment where we can say, I understand where you're coming from, and we're here to help you, not to critique you. We're here to make you better and not try to push you out. Why would we bring you in just to push you out?
Yeah.
Right? We want to create an environment that's conducive to your success.
I love that.
And we want to help you. And so we need to foster in new hires and people coming in that kind of an environment for them.
I love that.
Yeah.
And because it's something that is missed a lot of the times.
Oh,
And,
totally.
you know, I feel like we do a pretty darn good job of onboarding new people, especially with my most recent experience of being the new guy again, which sucks. It sucks being the new guy again. Even though I've known you guys for years, it just sucks being in a new system, or it sucks learning everything over again, right?
Totally.
But, you know, like Brian said, that fostering of good community is what really brings us up. So I appreciate that, man.
Yeah, man. We got to keep the team dynamic good.
Yeah.
You know, because if you find yourself in a spot where like you feel like you're with the partner that you aren't sure about, and you feel like maybe you're not sure if you can trust them, you're not sure if they're making good decisions, you're not sure if they're really up to par, you know, in the end of the day, like that affects the entire team dynamic.
Yeah.
Right.
It really does.
And that's ultimately in the end, like, I mean, we live with each other.
Yeah.
Like we've got to be able to make these relationships work, you know?
Yeah.
It's difficult when you have someone that's like that as well, that you can't trust or whatever it is.
Mhm.
But, the reason that it's called that imposter syndrome is because it's not that you don't know what you don't know, but you understand what you don't know, but you don't admit it. Right?
Yeah.
You're hiding that, basically. You're hiding the fact that you just don't know. And we can't have that. You can't be that way. It is okay to be like, hey, I need help on this. Right? Again, I thought, yeah, I know vents. Cool. Right? When we did some critical care ground transport stuff, it was like, yeah, I was a vent guy. I was great. I knew my stuff. I didn't know shit.
Yeah.
Right? And that was more, again, I didn't know what I didn't know until all of a sudden I see it. And then it's, don't be afraid to admit, like, whoa, hey, I was way off on this, so help me out.
Yeah.
And that's, for me, that's what it was. Like, okay, I need help. But, yeah, don't be afraid to ask for help. And especially coming in from ground EMS to this flight gig, I mean, it's a big difference.
It's
Really, it's huge.
step.
Yeah, it's huge.
It's completely different. It is not the same job.
Yep.
And
There are a lot of people that think that all we do is an ambulance with wings, when that is the farthest from the truth.
yeah, it's crazy. Because when you have to sit there and, again, you have to make that phone call and talk to the neurologist or talk to the, pediatric intensivist and go through all this stuff. Like, you better have your crap together.
Yeah, when they sit there and start drilling you
can't
on
fake that
interventions,
stuff.
you can't fake that.
No, and you shouldn't.
And it also comes down to something as simple as basic operations. Like, I felt like I was doing pretty good until my first solo ride day off of my orientation with our company. And I got in the front seat of our helicopter and I went, oh shit, I've only been up here once in the last 2 weeks.
Yeah.
But that's when I just had an open conversation. I said, hey, pilot, this is my second time being up here. Will you just make sure that I don't sound like an idiot and that I know what I'm doing up here?
Yep.
And they went, absolutely. And it's that easy.
Yep.
Just to show,
Right.
A little bit of humility in knowing what you don't know.
Yeah, absolutely. And that's, for me, I mean, that was one of the reasons that I was like, okay, I had applied for flight jobs before and wanted to go fly, and it was cool. But the reason when I got this job and I really applied for it and said, like, I want to be there because I see my friends and I see people I've worked with and people I've taught, like they're on a different level than me right now.
They're surpassing.
I don't like it. Like,
Yeah. I don't like the way this makes me feel.
I love working with that guy, and it's great. And these people are awesome, but I want to get there.
Yeah.
So I need this.
Yeah.
You know, but and it's okay to. And I have conversations with my partner all the time. I learn from her every single shift. It's like, okay, I don't know this. What are you talking about? Like, help me with this. So don't be afraid. Don't be the imposter, right? Have those conversations. If you need help with something, get help. Because it's only going to make you better. And then use that knowledge that you've learned and teach somebody else.
Yep. The last thing you want to do is find yourself falling into complacency.
Oh, yeah.
And just going with what you're only up to the point where you're comfortable.
Yeah.
And where you think you know, when there's a lot of other things that need to get done.
Yep.
For the patient's sake. And you find yourselves not doing that. Slipping on assessments, slipping on interventions.
Yeah.
Right? Because in the end,
We're just
what are we here for? Right? I mean, we're here for the patients.
Yeah. And we're like not even, or we don't need to do that intervention. They can do that in the hospital. Like,
Oh, that drives me nuts.
get that stuff done because you're complacent, because you don't know.
Right.
Because I haven't done a chest tube, so we can wait.
And that's just another, even and that's a path you fall into, but it just adds on to making you look like you don't belong when that may not actually be the case.
Yeah.
So
awesome.
Dude,
Brian, appreciate it.
thank you so much.
yeah, dude.
My Florida homie. You didn't come with a gold chain and a wife beater today, so
No.
I was
No.
pretty disappointed in that.
Oh, I'm sorry. I left my Florida costume at home.
It's so good to have you in Idaho.
I like being in Idaho. I don't know if I want to live in Idaho.
There's a house with a pool for sale behind me. I know that's one of your things.
I do like that.
So, but no, dude, we really appreciate it.
Yeah, dude, I would love to do this again.
Yeah,
Absolutely.
Yeah, anytime.
absolutely. Come on, you're always welcome.
Always welcome. Appreciate you.
Absolutely.
And thank
Thanks,
you
guys.
guys.
You got to be our first podcast guest. Well, second because of the medical
Second.
director.
Yeah.
But,
Yeah.
this just makes my heart happy. But anyways, I'll let Isaac do the wrap up. Ladies and gentlemen, thank you.
Yeah, wrap it up. All right. There's my rule.
Yeah.
There's my EMS rule. Wrap it up. So, no, thank you guys so much for listening in. We appreciate you. Look forward to seeing you in the next one. Thank you. And like always,
Stand by for tones.